Hello, welcome to the webinar examining the current evidence around the early use of opioids after work-related low back injuries and work outcomes. We're glad that you're here. My name is Mark White and I'm the President and CEO at the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the community grant program from the BC government, as well as donations and memberships to the organization. We thank our program partners, the Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll just go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be having or to ask any questions that you have related to the presentation. We will collect questions submitted through the presentation, and following the presentation there'll be a Q&A based on the questions that were submitted. Following the webinar, any questions not answered in the allotted time will be sent to the speaker, and then we'll create an FAQ after the event. The presentation will be recorded and posted for free on our website within a week, along with information about the speaker. You'll be emailed the direct links for the webinar, for the recorded webinar, once it's available. As I mentioned, my name is Mark, and I'll be moderating the webinar in the Q&A session. And our presenter today is Dr. Nancy Carnide. Dr. Nancy Carnide is a postdoctoral research fellow at the Institute for Work and Health in Toronto. She has a PhD in epidemiology from the Dalla Lana School of Public Health at the University of Toronto. And during her PhD, she was the recipient of a Canadian Institute of Health Research Vanier Canada Graduate Scholarship and a CIHR Strategic Training Fellowship in Work Disability Prevention. Dr. Carnide's current research interests lie at the intersection between occupational health and safety and substance use, and her doctoral dissertation focused on the use of prescription opioids among workers with work-related low back pain and their association with work disability. Her emerging program of research builds on this work to examine the use and non-medical use of prescription and recreational central nervous system drugs among workers, their risk factors, and the workplace consequences of their use. I'm thrilled that Dr. Carnide is available, and we're looking forward to your presentation. Thank you, Nancy.
Great, thank you, Mark. So hello, everyone. I'm happy to be here today to present some of the findings from my PhD work that focused on the early use of prescription opioids for work-related low back injuries and the relationship with work disability. And so first, I just want to acknowledge my other team members. So this was my thesis committee that also contributed to this body of work. So my supervisor is Sheila Hogg-Johnson, and my other committee members were Andrea Ferlin, Pierre Cote, and Mika Cohorn. So as you all know, low back pain is common among working-aged adults, and it's among the leading diagnoses of workers' compensation claims in Canada, accounting for about 25% of accepted lost time claims. And it's also a leading cause of work disability among workers in developed countries. Now, for most acute episodes of low back pain, rapid improvements in pain and function are typical, even in the absence of any intervention. And most individuals with low back pain do not go on to develop chronic symptoms. However, it is now recognized that low back pain is an episodic condition and recurrences are common. Pharmacologic management of low back pain is often considered the mainstay of medical treatment of symptoms. And historically, treatment guidelines for acute and subacute episodes of low back pain have generally recommended trying acetaminophen first, followed by nonsteroidal anti-inflammatory drugs. And if the pain is uncontrolled or is unlikely to be controlled by these drugs, then a short course of opioids or muscle relaxants may be considered. Now, notably, the most recent guideline published by the American College of Physicians has removed mention of opioids in their treatment recommendation, opting instead to recommend that clinicians choose NSAIDs or muscle relaxants if pharmacologic treatment is warranted. And this recommendation was based on the findings of a systematic review that synthesized the evidence from randomized controlled trials on the effectiveness of various pharmacologic therapies in reducing pain and improving function. And what this review found was that there was no evidence available comparing the effects of opioids to placebo on pain and function, or any evidence from comparative effectiveness studies. And of course, we know that opioids carry a significant risk of serious harms, and many would argue that the genesis of the current opioid crisis resulted from an overprescribing of opioids for non-cancer pain conditions such as low back pain, for which there was no evidence to support such a practice. So back in 2005, in the midst of the developing opioid crisis, researchers from Washington State published the first paper to sound the initial alarm on opioid use among workers' compensation claimants. So this graph from their paper shows the number of opioid prescriptions that were being reimbursed by the state compensation system from 1996 to 2002, which was really at the beginning stages of this crisis. And they did this according to the type of opioid. So in the US, controlled substances such as opioids are placed in different schedules. So Schedule 2 opioids here, or drugs here, are drugs that are considered to have a high potential for abuse. And so that can include oxycodone, fentanyl, morphine, and hydromorphone. So typically what we would consider the strong opioids. Schedule 3 drugs are defined as drugs with a moderate to low potential for abuse. And so this typically here would include Tylenol with codeine. And then Schedule 4 drugs have what is considered a lower potential for abuse. And I think the only included opioid here is tramadol. And so you can see from 1996 to 2002, the number of prescriptions was increasing. And this was mainly attributable to prescriptions for the most potent opioids. So the proportion of opioid prescriptions that were Schedule 2 opioids increased from 19.3% in 1996 to 37.2% in 2002. And during the same time period, accidental poisoning deaths also increased substantially, with 32 deaths classified as definitely or probably related to accidental overdose of opioids. And of particular interest to this talk, in 62.5% of these deaths, claims were for low back pain. So since that paper, there have been a multitude of studies looking at opioid use among workers' compensation claimants, including those with work-related low back injuries. In a couple of non-peer-reviewed reports, back pain was considered to be a common reason for which injured workers received opioid prescriptions. And one of the key concerns has been around what appears to be early use or prescribing of opioids among claimants. A number of studies have been published that suggest that despite guideline recommendations, opioids are commonly prescribed in the early stages of low back pain claims among workers' compensation claimants. So anywhere from 5 to 34% of claimants in these studies received an early opioid reimbursed by the workers' compensation system. The definition of early varying from study to study. So in some cases, it was within 2 weeks, other times within 4 weeks of claim, and then another looked at within 6 weeks of the first post-claim medical visit. So it did vary, but essentially these studies were all looking at prescriptions in what we would consider the acute or subacute stages of a low back pain episode. And so the question is, what impact do these early prescriptions have on work outcomes? So this was something we set out to determine in a systematic review. And in this review, musculoskeletal disorders of all types were eligible for inclusion. not only low back pain. And we were interested in synthesizing the evidence not only from any available randomized control trials, but also from observational epidemiologic studies, given that work outcomes are traditionally not considered as outcomes in RCTs. In the end, we only found 5 studies that actually considered work outcomes, and all of which were observational cohort studies, and 4 of which looked at workers' compensation claimants with back-related injuries. Overall, 3 of these 4 studies found a significant association between the provision of early opioids and prolonged work disability, as measured by receipt of wage replacement benefits. And 1 study found that a shorter time between prescriptions was associated with reduced disability. Now, these studies have typically been interpreted as demonstrating a causal association between the early use of opioids and work disability. But when we delved a little bit deeper into these studies, we found that they had some key methodological limitations that call into question our ability to interpret this relationship causally. So, in particular, the previous studies relied on workers' compensation billing data, which likely led to incomplete prescription capture, as claimants may have used other means to purchase their medications. They also defined opioid receipt as being early, but they did not have pre-injury information to know whether claimants may have been receiving these medications before their claim, or whether they had already started to experience symptoms before reaching a threshold where they needed to file a claim and take time off. There was also what we call misclassified exposure time. And what I mean by that is that the time on benefits that was accumulated prior to the first opioid prescription may have been attributed to the opioid exposure, when really only the benefits that occurred after the exposure should have been considered as potentially due to the opioids. And finally, confounding bias was a particular concern in these studies. For those who aren't familiar with this term, confounding is when another factor other than the one you're interested in is associated with both your exposure and your outcome. And if you don't account for that extraneous factor, it can suggest there's an association between your exposure and outcome, when in fact, the outcome is actually being driven by the confounder. So in this case, confounding by what we call indication and severity, is of particular concern, with the idea here that the underlying reason for receiving the opioid, which could be anything from pain intensity, poor function, distress, injury severity, those underlying reasons may have been driving the disability and led to the associations we saw, because most of these studies inadequately accounted for these extraneous factors. And other potential confounders that were also not considered were prior experience with opioids and prior healthcare utilization, which could influence both post-injury prescribing and also be associated with the worker's recovery trajectory. So having reviewed this literature, we felt there was a lack of convincing and valid data of the impact of early opioid provision on work outcomes. So since that review, 2 other studies have been published. This one is out of Ontario, and they also found that receipt of an early opioid was associated with longer time on benefits, and using very similar methodology to the previous studies. And another study out of the US actually found there was no association between opioids provided in the emergency department after a work-related low back pain injury and time on benefits. However, I will say that these studies demonstrated many of the same limitations as their predecessors. So we saw an opportunity to use data from British Columbia on claimants with low back pain injuries to begin to address some of the limitations of the existing literature. And for today's presentation, I will be presenting the findings of 2 pieces of our analysis. So the first is a descriptive piece where we looked at the pre-injury prescription dispensing experience and compared it to the post-injury dispensing. And then the second piece is re-examining the relationship between early opioids and work disability while accounting for some of the limitations of the previous studies. So just to give you an overview of the overall study methods, the study design was a historical cohort study. The source population was employees in British Columbia who filed a new low back pain short-term disability claim from 1998 to 2009. And in BC, approximately 93% of employees are covered by WorkSafe BC, which is the workers' compensation system in British Columbia. The main eligibility criteria for inclusion in the cohort were that claimants had to be at least 18 years of age at injury. They had to have an allowed claim with at least 1 day of benefits within the first 8 weeks. They had to have non-specific low back pain diagnosis. They had to have no low back pain related hospitalization or serious outpatient encounter within 5 days after injury. And they had to be eligible for health services and have no cancer-related health care for 2 years before injury and through 1 year after injury. The data for the analyses were obtained from longitudinal person-specific data from 5 administrative data sources delivered by Population Data BC. So for each claimant in the cohort, the data included information on workers' compensation claims, outpatient billing records, data on hospitalizations, and claimant demographic data. And we also had information from PharmaNet, which is a prescription monitoring program in BC that contains detailed dispensing data for all prescriptions dispensed from community and hospital outpatient pharmacies in BC, regardless of who paid for the prescription. So that, I think, is a key benefit of the data. And another benefit of this data source is that we also had access to pre-injury prescription and healthcare utilization information as well. So the overall cohort, we had just over 97,000 claimants. It was made up about 62% men with a mean age of 40, and approximately 33% had at least one prior workers' compensation claim in the 2 years before the injury date, and 87% had a low back pain sprain or strain diagnosis at injury. So as I mentioned, the first part of this work was a descriptive analysis to really try and understand both pre-injury and post-injury dispensing in low back pain claimants. And not only for opioids, but we also wanted to consider drugs that are also commonly prescribed for acute and subacute episodes of low back pain. So the specific objective here was to describe and compare prescription opioid, NSAID, and muscle relaxant dispensing 1 year pre and post-injury, and determine whether the post-injury dispensing returns to pre-injury levels. This paper was recently accepted in the Journal of Occupational and Environmental Medicine, and it has been published online ahead of print if anyone is interested in taking a look. So I'll just give you a little background on some of the results that we found. So this is a table that gives you the proportion of claimants who received at least one prescription by drug class. And so what we found was that all 3 drug classes were being commonly dispensed, particularly in the post-injury period. So as you will see, about 50% of claimants received at least one NSAID prescription in the 1 year after injury. 38.8% received one or more opioids, and 28.4% received at least one muscle relaxant. But you can also see that for opioids and NSAIDs, these are also common in the pre-injury period. When we look specifically among claimants receiving opioids, you'll see that we've broken it down in terms of the strength of the opioid received and the length of action. And so what this tells us here is that weak and short-acting opioids were most common. So for instance, 95% of claimants received who received opioids either in the pre or post-injury period received weak opioids. So it was for the majority of claimants who were receiving opioids, they were receiving weak opioids and short-acting opioids, and it was most commonly codeine. When we looked at the daily morphine equivalent dose, which is an opioid dose that's standardized across all types of opioids, we found that the average did not differ from pre to post-injury, and it was not at a particularly high dose. It hovered at about 31 milligrams per day in both the pre and post-injury period. And we also looked at the median day supply of each drug class being received by claimants. And we found that opioids were being provided for a median of 8 days here in the pre-injury period, compared to 10 in the post-injury period. And a similar increase was seen for NSAIDs, so from 15 to 18, while cumulative days supply stayed steady for muscle relaxants at 10 days in both the pre and post-injury periods. We also looked at how dispensing patterns varied across different 8-week periods in the year before and after injury. And so if you look at this graph, the lighter portion is the pre-injury. So there's 6 8-week periods in the pre-injury stage, and then 6 8-week periods in the post-injury stage. And so the injury occurs right here. And we chose 8 weeks because WorkSafe BC policy at the time of the study was to limit reimbursement for opioids to the first 8 weeks after injury in most cases. So again, each of these sort of columns here, these blocks, refer to these 8 weeks. And what we see is that for each of the 3 drug classes, dispensing was generally fairly stable leading up to the injury, and then peaked immediately after an injury in that first 8-week period. So about 28% received at least one opioid prescription in the first 8 weeks, 41% in NSAID, and 25% of claimants received a muscle relaxant in the first 8 weeks after injury. And in fact, when we looked at the median number of days that it took to receive the first prescriptions, we found that first prescriptions were received at a median of 6 days for opioids, 4 days for NSAIDs, and 3 days for muscle relaxants. When we look at the pattern of what happens after that 8-week period, we see that dispensing drops over time. But for all 3 drug classes, it remains slightly elevated in the post-injury period here, compared to what we see in the pre-injury period for a small proportion of claimants. So this is looking at the same thing, but looking at among claimants with opioids and according to the strength of opioids and the length of action. And what we find here is that, again, it's fairly stable before, but we do see over time after injury an increase in dispensing for strong opioids as well as for long-acting opioids. And this is looking at the average cumulative days supply per claimant for each of the 3 drug classes. And really what I just want to take away from this is that for all 3 drug classes, the average cumulative days supply remained about 20 to 30% elevated in the post-injury period compared to what we were seeing in the pre-injury period. So in summary, I think the dispensing patterns suggest that the injuries were generally acute and prescription treatment was of short duration. But for a small subgroup of workers, they received prolonged courses of treatment that suggest that they may be experiencing a delay in recovery. But so as I mentioned, we wanted to understand what impact these sorts of prescriptions in that earlier period, the first 8 weeks, had on subsequent work outcomes. And one of the things that hasn't yet been done was to assess the comparative effect of early opioids relative to NSAIDs and muscle relaxants on the incidence of work disability, because as you can see, they also are very commonly prescribed in that early period. So the objective of this second piece of the analysis was to determine if dispensing patterns of prescription opioids, NSAIDs, and muscle relaxants in the first 8 weeks following work-related low back pain and compensated injury are associated with work disability over 1 year. And we aim to minimize the limitations of the previous research, including ensuring there was a separation of our exposure and outcome windows, using a comprehensive prescription data source, in this case, PharmaNet, accounting for pre-injury factors that could influence both post-injury dispensing and work disability, and minimizing the potential for confounding by indication and severity by limiting the analysis to only those workers who had at least one prescription for one of the 3 drug classes, and thus an indication for pharmacologic treatment. So we removed anyone who didn't have at least one prescription for one of the 3 drug classes under the assumption that they may have already been doing better. So as I mentioned, we wanted to ensure separation of our exposure and outcome windows. So we looked at 4 exposure variables, which were right here, which were all based on dispensing patterns in the first 8 weeks after injury among claimants with at least one dispense. So we looked at the overall drug classes that were dispensed in that 8-week period, the cumulative days supplied for each drug class separately. And then among claimants receiving opioids, we looked at the strength of the opioids that they received and the average daily morphine equivalent dose. Our outcome variable was the number of days on wage replacement benefits, which was based on the window of time after the first 8 weeks and up to 1 year post-injury. And we also considered a number of potential confounders. So from the pre-injury period, we looked at prior workers' compensation claims, pre-existing comorbidities, including other pain-related and mental health comorbidities. We also looked at various healthcare utilization indicators and use of prior prescriptions, and not only for the 3 drugs of interest to our study, but also drugs that are often used as adjuvants in pain management. So antidepressants, anticonvulsants, and sedative, hypnotic, and anxiolytics. We also considered sociodemographic and occupation factors, as well as the diagnosis and year of injury. And finally, we adjusted for any specific concurrent healthcare utilization indicators, as well as prescriptions that occurred in that same 8-week period. So the first exposure that we looked at was drug class, the drug class that was dispensed in the first 8 weeks. So we categorized claimants according to whether they had only received NSAIDs and or muscle relaxants in that 8-week period, claimants who received only opioids in that 8-week period, and then claimants who received opioids with NSAIDs and or muscle relaxants in that 8-week period. And so what we found is that after adjusting for our confounders, when we compare to claimants who received only NSAIDs and muscle relaxants only in that first 8 weeks, we found that the incident rate ratio for those who received opioids only was 1.09, and it was 1.26 for those receiving opioids with NSAIDs and or muscle relaxants. And so what this tells us is that the rate of time on benefits was 9% higher for those receiving opioids only compared to those who did not receive any opioids, and 26% higher for those receiving a combination of opioids with the other drugs. We also looked at strength of opioids. So again, we categorized claimants according to whether they received weak opioids only, strong opioids only, or a combination of weak and strong opioids within that 8-week period. And we see a bit of a similar pattern. So claimants who received strong opioids only had a rate of benefits that was 21% higher than those who only received weak opioids. And those who received both strong and weak opioids had a 29% higher rate of receiving benefits. We also looked at the average daily dose of opioids received among claimants who had received at least one opioid. And we see a small increase in the rate of benefits associated with increasing dose. So for every 30 milligram increase in daily dose, the rate of benefits increased by 4%. And finally, when we looked at cumulative days supplied with each of the 3 drug classes, we found a weak relationship for all 3 drug classes, suggesting that those who receive longer supplies in that first 8-week period were at a small, higher risk of prolonged disability. The estimates were somewhat stronger for opioids, but again, we see a relationship for the other drug classes as well. So I think, the findings are generally consistent with the previous research, although the strength of associations seen in this study were much attenuated compared to those seen in prior studies. And it's likely a result of the methodology and attempts to limit or to minimize the limitations that were seen in previous studies. But I do think that there is, unfortunately, still reason to suspect that residual confounding is accounting for some of the results. Namely because there was evidence suggesting that the association was stronger for workers receiving drug combinations, which might suggest that those who are doing worse to begin with and maybe needing to try various drugs are also the ones to have a longer time on disability. And the other thing that makes me think this as well is that we didn't just see a relationship between increasing cumulative days supplied for opioids, but we're also seeing it, some evidence of that for NSAIDs and muscle relaxants as well. So I think while these findings do suggest a possible relationship between early opioid provision and work disability, further research I think would be needed before we can interpret this association causally. So in terms of future research, I think we certainly need to expand to other work outcomes beyond time on benefits. My study, previous studies, we've all used wage replacement benefits as our outcome. But I think we need to start to expand that to look at things like return to work, actual return to work, at-work functioning, workplace safety outcomes, to really better understand the impact of opioids on workers. In addition, all previous studies, including this one, have considered only the impact of claimant level factors as potential confounders of the relationship. And certainly I think we need to do a better job of addressing the influence of injury severity and prescription indication on this relationship. So that includes isolating the effects of factors such as pain intensity and functional status, psychosocial factors such as worker distress and recovery expectations. So we certainly need to do a better job of that. But we also know that development of work disability doesn't occur in a vacuum, and there really needs to be consideration, I think, also for the role of other factors that may influence prescribing and the recovery trajectory of claimants. So this includes the role of the prescriber. So in addition to providing medical treatment, physicians often play the role of gatekeeper in a workers' compensation context, and they likely vary in how they manage workers' compensation patients. So on one hand, it may be possible that a physician who may be more aggressive with treatment may also be aggressive with recommending an early return to work. On the other hand, a physician who feels the pain of a low back pain injury necessitates opioids may also be more inclined to recommend a greater need for recovery time. So I think we really need to consider how the prescriber may also be influencing this relationship. And I think we also need to consider the role of workplace factors and how that might be influencing. So this could include things like availability of work accommodations. Are there any accommodations? What the employer response is to the worker. Is it supportive? as well as system level factors. So things like what are the return to work policies that might be at play? Are there claim related delays that might influence things? And accessibility to non-pharmacologic treatments. How accessible are they? Are there delays in being able to access them, and are they being funded? And finally, I think if opioids are causally related to work disability, there really needs to be a better understanding of what the mechanism is that underlies this relationship, because it's not very clear. Is it side effects of opioids that may be delaying work disability? Is it, the development of potentially problematic patterns of use? This isn't something that's very clear, and so I think we need some sort of plausibility here of why that might be, why there may be a relationship. So I think, given the findings, true cause and effect between the use of early prescription opioids and prolonged work disability can't yet be assumed. However, I will say this study and others have also not demonstrated a beneficial effect of opioids on work disability. And of course, we know that there are inherent risks of very serious harm associated with opioid exposure. So I think clinicians should continue to remain cautious in prescribing opioids to injured workers with low back pain, as there really is, at this point, no evidence to suggest that it helps. But at the same time, I think there also needs to be ensuring that clinicians continue to ensure that pain is adequately treated. And finally, I think policymakers should also use these findings cautiously and not only consider how opioid exposure can be reduced, but ensure that there is timely access to alternative pain relief measures for this pain population. So the disclaimer that I have to say here is that this presentation does not reflect the opinions or policies of the data stewards that provided the data, or the province of Ontario, who helps to fund IWH. And I just want to acknowledge the funders of this work, so WorkSafe BC and CIHR, as well as those who had provided funding, personal funding for me during my PhD, and those that also provided data for this study. And here is my contact information if anyone has any questions that they may want to ask at a later date. And I think I'm pretty early, but I am welcome to take questions now, if anybody has any.
So thank you very much, Nancy. It was wonderful to see the progression of how your earlier doctoral work then informed creating a study that could look at it in more depth. And so that was wonderful to see that progression, because sometimes you don't see that progression and you don't see it very swiftly. So so that was marvelous. Thank you very much. So if you do have questions, please use the chat box and send in questions. While we're waiting for questions, I thought it was interesting, first, the issue of severity, and not really getting any sort of good markers to really understand severity with administrative data. Mm-hmm. And I just thought that it would be interesting to hear a little bit more about your perspective on that.
Yeah, I mean, I think for sure with administrative data, it's certainly very difficult to identify anything that could be indicative or can really best measure severity. So a lot of people will use the ICD-9 diagnosis and try to classify it in that way. But that's a very crude way of being able to understand severity. And really, I mean, there's a lot of different things that sort of, it's it could be severity, but it could be a lot of other things. It could be a lot of psychosocial factors that could be driving prescribing and driving disability. And those are things we just can't get out of the administrative data. But what we were trying to do here is at least minimize that sort of confounding by severity and indication by at least saying, okay, let's take out all the people who didn't have any prescriptions. Because if they're not taking these prescriptions, perhaps they're doing better to begin with. And so we don't want that to influence our findings. And we don't want to make those comparisons between people who are receiving these prescriptions to those who haven't received anything. And so we were really trying to level the playing field a little bit by taking that group out and minimizing that. But I do think that there's still something going on that we're not able to account for here. And, I think that's something that down the road, if we really want to understand how opioids are maybe influencing work disability, we just need to do a better job of taking into account all of those extraneous factors, not only injury, severity, or indication, but all of these other things that could be influencing whether a claimant is getting an opioid and how the claimant's recovery is going.
I thought it was also interesting that when you looked at the prescription history as well, and to me it seemed like it was fairly high when you're looking at the pre-injury prescription use within that cohort. So
yeah, and so it was. I think it. When we sort of that one table where we just look at sort of the proportion of claimants who are receiving at least one of the drug classes, that certainly was high, I think, in that pre-injury period. But it really was, for the most part, most claimants were receiving one, maybe two prescriptions, actually in both the pre and post-injury phase. So when we looked at it by those 8-week periods, really, it was sort of this sort of background prevalence of about, 5% in any given 8-week period of claimants who are receiving at least one prescription, which I think is a bit more reasonable. It kind of gives you an idea of what's happening throughout that 1-year period.
yes, okay, yeah. In a future study, you talked about you talked about also issues related to looking at prescriber practices, as
Yes.
well as looking at aspects of psychosocial components. It could also be the type of whether or not someone's going back to a workplace with more physical demands
Yes.
as well. Do you have some ideas on how one might be able to construct something?
That's a $1 million question. A lot of most of these studies, I think, except for one, maybe two, it was strictly based on administrative data. So the Franklin paper that I had cited before, they did use some primary data collection to collect some of that information. And then their outcome was based on administrative data. But yeah, I think the only way that we would be able to do that is to do a sort of a primary, I think ideally we would do some primary data collection combined with linking it to some administrative data. But I think it would be a large undertaking, but it would be very interesting to be able to see the recovery outcomes based on different types of treatment. And again, like as I mentioned, a lot of these in RCTs, they don't really consider work outcomes. So they consider pain, changes in pain intensity, changes in general function, but work is never really an outcome in these studies, return to work or anything. So we're sort of stuck with these observational epi studies. And it's just trying to do a better job of making sure that we sort of check all of the boxes and really try to understand all of the different factors at play.
So I'm going to go through some of the questions now that are coming in. So what do you consider as alternative pain management options in your third last slide, I think?
Yeah, so it could be, I mean, a number of different things. Of course, I don't know if I have that guideline up, but it could be different. So physiotherapy, massage, chiropractic, acupuncture, other things that where it may be more difficult to get sufficient funding for, and to be able to financially to pay for those things. So prescriptions are generally much more covered, and even in a workers' compensation setting, there are a number of qualitative studies that suggest that claimants sort of have these barriers to getting timely access to these alternative treatments. So, and I shouldn't say alternative, but just non-pharmacologic treatments. So I think that's sort of what I was saying there.
Okay. And do you know, is codeine and Tylenol 3 an opioid is one other question?
Yeah. Yeah. So, and I would say a lot of people here in this cohort, that's what they were using.
Okay. And I think that's it for questions. A few comments, like great presentation, and thank you, Nancy. Someone just noting that it was very informative and well put together session.